And good evening to everybody. Welcome to this week's Maternity and Midwifery Hour. This is the 9th episode of the 3rd series of Maternity and Midwifery Hour. My name's Sue MacDonald and I'm the curator of this Midwifery Hour and also the Midwifery and Maternity Festivals. So it's my pleasure to be here chairing this evening. And as many of you will know, this evening these sessions were designed in response to the COVID pandemic as a means of making sure midwives, student midwives, and loads of people in the maternity services had some access to information, continuing professional development during that time, because obviously we haven't been able to have face-to-face festivals or study days or conferences. So this is a way of countering that and making sure you get some interesting material and learning, which is fantastic. And tonight we're looking at postnatal care, sometimes called the Cinderella of the maternity services. I think my guests here will probably think it should be the jewel of the maternity services, really. And we need to ensure quality and support from pregnancy to that transition to early parenthood and the early parenthood. So I'm absolutely delighted to be joined by Elizabeth Duff from the NCT and Logan Van Lessen from the Whittington here in London. And welcome to both of you. I'm so glad you're with us this evening. Now we always start off the evening and I've put both Logan and Elizabeth on the spot to ask them for their moment of the week. So can we start with Elizabeth maybe?
I was warned about this, but I had forgotten till just now when I was reminded. But I'm going to take a moment in personal life just from today, because we are about to move house away from where I've been living for getting on for 40 years. Wow. And both my daughters and my little grandson came round today to say goodbye to the house. So although quite a lot of it is already packed up, it was quite a funny but emotional few moments, just going round and saying, oh, well, that's the last time. But we will have a new house and we will all meet again. And it's lovely to be here.
Gosh, that is a real rite of passage, though, isn't it? Moving from one house. Gosh, oh, real emotional thing. Thank you for that, Elizabeth. Oh, how about Logan?
Well, thank you. Good evening, everybody. Good evening. It's so lovely to be here. When Sue kind of asked, and I thought, oh gosh, what was been so special? And it wasn't this week, actually, it was last week. But I am a trustee of the Untitled Midwifery Trust, and we had a fabulous awards ceremony virtually last week. And it kind of really warms you that Sorry, can you hear me now? Yes. Yeah. Did you hear me at all, or have you got my? Okay, right. So in terms of the awards, the ILNT awards happened last week. So there were some fabulous awards for midwives and student midwives, and I just think that in COVID times, that was really a very warm spot last week. So yeah, that was my kind of moment, if you like. And trustee on the board for the first time. So yeah.
Wow, that sounds fantastic. Absolutely a really heartwarming for both of you. Really good event. So thank you for sharing those with us this evening. I just have to reiterate that, because I always do on this, that this is provided by Netflix, and this is where you need to go if you have an assignment to do, if you've got revalidation to think about. It's a very good source of information. For example, this session tonight, which is going to go out now live, and later on in the week and a bit later, it will be accessible after this time, and you can share it with your colleagues and your friends and have a discussion about it, and that can be part of your revalidation for those of you who are looking at that. Just at the moment, I just need to really think about the fact we're still in lockdown. We've still got this roadmap. I've got roadmap steps by my side at all times, just to keep track of how and what we're meant to be doing. it's very easy at the moment, I think, especially as people have had the vaccination. Some folk are getting, quite excited about, oh, we can do this, we can do that, we can do the other. And of course, we still have to follow our social distancing and our masks and just trying to stay at home as much as we can. So keep with it. We're getting there. But there is still a lot of people who are sick in hospital, and we send our good wishes to the people who are in hospital poorly, but also those staff who are working so hard to look after them and care for them and their families. So thank you to those people in intensive care, in the high dependency units, and in the medical wards who are looking after people. We always also say a big thank you at this point to our maternity service colleagues, because though some people have been redeployed, most maternity services have carried on, because guess what? Women are still pregnant, having babies, and need that care. And so a big thank you to the midwives, the student midwives, maternity care support workers, all the people that keep everything going in the maternity service for women and their babies and their families. And we've added our thanks to people in the vaccination centres who are doing such fantastic work, doing the vaccinations and getting the sort of rate of COVID right down, which is fantastic. And again, a big thank you to all key workers, everybody who's keeping the whole country going and keeping us going. Now, I always, at this point as well, go on to the news. We've had the budget, and I'm not going to go on too much about the budget, because many of you will be hearing it all day and all evening, and it's quite hefty going. But the key things is the furlough is carrying on till September. The top up of £20 a week benefits are continuing for another 6 months. Wine, beer and fuel duties have been frozen. That may be good news for many people. And there's a stamp duty holiday for people as well for a while. So we're moving away from the budget. You'll be all relieved to know. And today is World Hearing Day and World Wildlife Day. And it's also the National Day for Bulgaria. I always like to have a little fact like that. So to anyone who's a Bulgarian who's listening in, have a lovely day, and I hope it has been a good day for you. Just also, vaccinations are very well underway. We're hitting over 20 million vaccinations. 20 million vaccinations. It's just incredible. So well done to everybody who's part of that. And it just reminds you when you hear someone like Dolly Parton singing the vaccination song. Any of you who are on Twitter will have probably seen that. But she's had her vaccination. She held back, even though she's put an enormous amount of her own money into vaccination processes in America. But she held back from having hers, but she's now had her vaccination, so that's good. I'm an avid tweeter, those of you who don't know. And a tweet of the day for me was a lady called Annie Bush, who talked about the Bosch huddle. And I thought this was a really good idea, which could be fitted in wherever. I think this is mainly used in medical care. I'm not sure. But it's a Bosch, so it stands for BOSH. B, you all get together, just 5-10 minutes at a shift, and you start off with B. Has everyone had a break? O, are we all okay? S, are there any sick people on the ward? And H, does anyone need help? And I thought that was a really good, quick checkout, just to make sure we're all looking after each other, because this is the real time we need to look after ourselves, but also look after each other. So I thought it was really good. You will all have noticed there's a resources page that's online, and that's got all the references you'll need for this evening. Some have come from Elizabeth, some have come from Logan, some have come from me. So do check that out. Okay, we're going to move without further ado on to the main meat of this evening, and that's to look at postnatal care, the Cinderella of the services. It's a time, and especially at the moment, when people feel very stressed, very anxious. The mum's coming home with a new baby. It's very scary, and midwives are really needed to provide postnatal care. And there's often some challenge about that, especially over this last period of time. So I'm really so pleased that I've got two fantastic speakers. We're going to start with Elizabeth Duff, and many of you will know Elizabeth. She is the National Childbirth Trust's Senior Policy Advisor, and she can discuss just about anything to do with motherhood, with women's issues around maternity services and birthplace. She's worked with the RCM and the International Confederation of Midwives in the past in communications and policy, that's her huge strength and skill. And in her present post, she's represented the NCT on national maternity reviews in both England and Scotland. So we're delighted she's with us this evening just to talk a little about postnatal care. So welcome, Elizabeth. The screen is yours.
Well, good evening. Thank you, Sue. I'm going to, without further ado, try and find, and I can see I've got my slides, but at the moment, that's it, I'm not at the first one for some reason. Well, I knew we weren't going to get away from the Cinderella image. And indeed, this has been around, I reckon, over 30 years that people have been referring to postnatal as the Cinderella service. And it will be very nice to feel that we can stop doing this quite soon. Apart from anything else, in my view, Cinderella is not really a very appropriate metaphor, because although she had a tough time and was badly treated by her stepmother and her stepsisters, actually, she did get a fairy godmother. She did get a lovely dress to go to the ball in. She did go to the ball. She did meet the handsome prince. And apparently, after the shoe episode, they got married and they lived happily ever after. So I'm going to try in these few minutes to see if we can get Cinderella, get some ideas for getting Cinderella a little bit nearer to that lovely, happily ever after life in the palace. But it is going to start a little bit bleaker. You probably all heard of Holly McNish, who's wrote some absolutely amazing, usually very short but very poignant poems about having babies, breastfeeding, great many things that are relevant to midwifery. And just giving you a few seconds to read through this one if you haven't known it before. But I actually feel the last three words here are often two key things for women who've become mums, especially for the first time, and come home if they've given birth in a hospital or outside the home. And in the first few days, there will be weeping and there will be bleeding. And up to a point, that's normal. But after a few days or even a few weeks, if mums are still weeping and still bleeding a lot of the time, that is not normal, but how do they know they need help? And these two are not the only problems, of course, that occur in postnatal care, but it just struck me that they are symbolic of the mental and emotional well-being that mums should be supported to have, and the physical recovery, the support through physical recovery that they also need in order to be the parents that they want to be. This is also rather a bleak slide. It will get better, I promise. And I'm sure that I'm not telling anyone anything new about what women have experienced, particularly during the recent months and the last year. And this is a very recent report from the risk study, the W-risk, which is a joint study run by the University of Cardiff and BPAS and funded by the Wellcome, but NCT have been joint investigators on it, and it's done some very insightful and helpful work about how to talk about risk to pregnant women. But they also did this report about the experiences, this one particularly about postnatal care during the pandemic. To be honest, much of what's being said here might have been said before the pandemic in the worst cases, because I have read similar things about women's experiences when they are in a service that is very overstretched. But I think a lot of these things will have been made worse during COVID because there is less face-to-face care. And midwives, we know, are so busy, and the workforce is suffering from sickness and those who have to isolate. So where it was overstretched before, it has been threadbare. I won't read out all this because I think you know it, but particularly with the first story, which is a woman on the postnatal ward, it just strikes me, she's saying, oh, the staff was so busy. The staff lacked time to explain things. She's not having a go at the midwives or the MSWs or the doctors or anyone else. She's very unhappy, but she knows that's because you're busy. She is actually being kind, compassionate and forgiving about midwives, and really shouldn't have to be the job of the women being looked after at that time. But we do hear this over and over again, perhaps because postnatal women are beginning to be full of oxytocin. They don't want to have unpleasantness and confrontations. They want to love their midwife as well as their baby. So repeatedly we hear, oh, the poor staff were so busy, I didn't like to bother them. But it shouldn't be what happens. I'm going to move on, you'll be pleased to know, to beginning to look about what ought to be done in postnatal care. I'm going to say these 10 points emerged. It's something that people at NCT with some other colleagues just pulled together, not really for one specific purpose, but just to try and summarize the things that came up over and over again. This is partly the result. We did published a report in 2010, a long time ago now, called Left to Your Own Devices. And a lot of these things, that was all about postnatal care. And I think the title speaks for itself. It was a woman's words that she just felt she was left to get on with it. We had a survey in 2013, which was published as Support Overdue, and we repeated that survey in 2017. So it's the results of these repeated surveys that showed this is what pretty clearly should happen. And many of these are set out in policy or set out in NICE guidelines or national policy documents, that all these things should happen. And they're not rocket science. They're not in themselves too ambitious or very expensive, but we know in a lot of places they're not actually happening. And a lot of the themes here, I think, the phrases like joined up, follow up, communication, consistent information, consistent content. It's about the fact that postnatal care happens in a service from too many individuals, too many different systems, too many employing organisations, hospital trusts, sometimes a different community employer, local authorities or Public Health England who are commissioning and providing the health visiting service, and then the GPs who run primary care according to a contract with the NHS, as you know. I haven't mentioned obstetricians, who some of whom are very interested in postnatal care and do like, where they possibly can, to see women who need more medical care. But these 10 things, I think, sum up a lot of what is needed. And I know that quite a few of these things were being done during the implementation part of the Better Births policy review. So there has been progress, but I think not enough yet. I wanted to take a little deviation to look at quality. Again, this is a quote from a document which is probably familiar to many from quite a few years ago, but I don't think much has changed. 3 key elements in quality care, and this could be any kind of care. So I would normally for maternity say woman-centered or personalised rather than person-centered, but that is the term in this Health Foundation work. And sadly, I think that postnatal care falls short on all of these. Most of it is safe, as most of maternity care in the UK is safe, but sadly, a lot of the maternal deaths that take place are in postnatal care, so we cannot say that it is safe. Effective is a huge question mark, because that means providing services based on evidence and produce a clear benefit. The evidence is widely lacking because research that covers the whole of postnatal care is almost absent in the last 5 to 10 years, I would say. Please correct me if I'm wrong. There have, of course, been studies of particular aspects of postnatal care, like infant feeding support or pelvic floor health, and of course, postnatal mental health. But what I feel is there should be quality right across the field of postnatal care, and that means somebody taking account of all these dimensions of quality. I'm going on to look at some groups of mothers. Again, I don't think that this is going to surprise anybody. There are a number of groups we know who are more vulnerable to worse outcomes from pregnancy, from birth, and of course from postnatal care. And I wanted to flag up really at the beginning those very small groups, fortunately, but very, very key in terms of those women who need postnatal care, those who are bereaved because their baby has died, those who are in prison, and we know there has been quite a bit of that care highlighted. It is very sparse for women who have to go straight back to prison without their baby, and some of the most distressing stories of maternal suicides have been related to that. Some women are very severely ill, mentally or physically, and cannot look after their baby. They still need postnatal care, very much so. And the fourth group I've highlighted here is where baby very sadly has to be taken away because the mother is deemed not to be able to be responsible for caring that baby. Again, those women need the postnatal care that all women should have after a birth. So please, small numbers here, but they need care. More groups who are more vulnerable to worse outcomes. These are perhaps more widely looked at, particularly we've got here the higher rates of mortality associated with women in the Black, Asian and minority ethnic communities, those from lower socioeconomic groups, older women, women who smoke, women with higher body mass index. And all of these have been paid more attention to during pregnancy and intrapartum care, but I don't hear so much about what happens to them in the postnatal period. If it puts them at higher risk during pregnancy and birth, they will remain at higher risk in general because all these things go on. They don't disappear. Women don't get a lower BMI or less age once they've had their baby. So we do need to think about these as much as we do in pregnancy and birth. During postnatal, how can we make sure they're all right and that appropriate follow-up is carried out? I'm going to switch for a minute to just saying I come from NCT. We do care a lot about women in the postnatal period, and this was a particular campaign that I hope you heard of. It reached its climax about a year ago when the demand we were making to have a properly funded and mandated postnatal check for women was agreed to in England, so that from April the 1st last year, this has been funded that all women should have this check. We are going to pick that up again next month and see if women are having it. I'm sure we'll be told, well, the last year hasn't been exactly a normal one, and I'm prepared to say back, no, it hasn't. Has the need for a postnatal check, especially of women's mental health, gone away? No, it hasn't. It is even greater than it was before. So this should be done. And the Royal College of GPs has agreed and is bringing guidance and training to its members. So we want to make sure that is happening. We are also updating all the time our information on our website. A lot of that is about COVID, but I wanted to flag up what we do in postnatal, because we feel, and this is from women's feedback, that knowing what is normal, go back once again to the weeping and the bleeding. How do you know how much of that is right? We do help on this. The picture there, a lot of you may be familiar, both either from real life or from seeing this page before. It's a baby's nappy on day 3 to 4. If you don't know what they look like, the different colours of baby's poo can be absolutely alarming for new mums. So that's just an example of what we do on the NCD website. I haven't got a slide about it, but I will throw in the fact that we've been wildly and manically putting out services for, not really wild and manic, but with great vigour and energy all across the country, running walk and talk groups for new mums and dads, so they can get together and meet new parents, other new parents in the locality in real life. And I cannot tell you how many times new parents have said that has been a lifeline to their sanity. And it means they can make friends in real life, then go home and pick up with all the online ways of doing that. So a few things that NCT has been doing. And I'm going to close about there, and we're going back to Cinderella. And I was told earlier this week in a completely different context that midwives love an acronym. So here we are. This is Cinderella. Back in the palace, there is the pink palace with those letters. And this is what I want to see, because I think this is about what the systems need to be, not the individuals. I know the individuals are out there doing what they possibly can, but we need postnatal action from the top. We need postnatal action in leadership, in accountability, and ensuring continuity and consistency. And we need equality or equity right across all those groups of women, all of them, including those who are more vulnerable to worse outcomes. I will be going on about this, particularly leadership for postnatal, because I think it is almost completely lacking when you look at that period from birth to 6 or 8 weeks. It's too fragmented. And if we had some leaders there, I think that would improve everything. So thanks very much for listening. That's me. And let's have some good discussion after.
That's great. Thank you very much, Elizabeth. It's good to have seen the palace at the end of the Cinderella bit. So it's fantastic. And thank you for reminding our watchers and our listeners that there is an opportunity for questions. So if you have any questions, do put them in the live feed now, and they'll come through to me. The why I keep looking over here is not because I'm doing something else, but I have 2 screens, and one screen the questions come in. So at the end of a Logan session, we'll have an opportunity for questions. So please send them in if you have them. That's great. Thank you very much, Elizabeth, starting us off. I'm now delighted to introduce Logan Van Lessen, who is a consultant midwife for public health. She's at the Whittington Maternity Services in London. She promotes the health agenda for women's maternity services at all levels and ensures that good quality evidence-based care is at the forefront of the maternity services she's working in. She leads on the Better Births workstream on community maternity services, and she's also the chair of the RCM Consultant Midwives UK group. And I know she's a very busy person as well as Elizabeth. So welcome very much, Logan. Thank you so much for coming. The screen is now yours.
Thank you very much. Good evening again, everybody. I'm just going to pull up my slides and hopefully they'll behave and turn up. There we go. I hope you can see that. Okay. Lovely. All right. So thank you, Elizabeth. That was really food for thought. And I think, like you, I'm very, very passionate about postnatal care. And I think what I'd like to kind of get across to our audience this evening is how important and crucial it is. It cannot be an add-on service. It's absolutely got to work. So I just wanted to introduce you to some very lovely penguins just to cheer you up on the first slide. So my talk will include COVID, some of the challenges, but you will recognize, many of you will recognize how we work. And I think I'd make some recommendations of how I think we could change postnatal care. My slide's not moving, and I don't know why it's not moving. Okay, let's just see. Okay, let's double click on that. Oh, sorry, it's gone back up. Okay, right. So we'll start with the journey, like you do. The woman doesn't get to the postnatal bit without the antenatal journey. And, you know, there are huge expectations, aren't there, around a pregnancy. Most women get to the end. In fact, everybody gets to the end. Some have fantastic journeys, some have mediocre journeys, and some people just don't have a very good journey at all. And that includes babies. But what do we do? Think about the way we nurture women antenatally. We certainly monitor them consistently. We see them throughout the 9-month journey. We scan them, we screen them, we advise them, and we hold their hands in many, many ways. And that contact, and some of them are lucky enough to make some really good trusted relationships with their caregivers. And then we build them up, and we build up, hopefully including families and partners for the actual birth. And if you think about that scenario of nurturing and trying to protect that mother and baby antenatally so that we have real positive outcomes and we take them through the birth process. And again, there are so many standards and targets to meet in line with, you know, meeting all the antenatal requirements around screening, all of that. And then in birth, we are mandated we're told we must provide one-to-one care in labor. And that's a standard we have to meet. So just hold that in mind and think about then what happens just after the birth. So we've built them up and we've given them this massive expectation. But the reality is somewhat different for so many of them. And as Elizabeth said, you know, as soon, it's almost a sigh of relief when the baby's well, the mother is well, and then the eyes come off the ball to look after the next lady coming in. But it is tough making that transition to become parents, let alone look after a new baby who doesn't really behave as you thought it might do. It's tough being a parent 24/7. And the mental health issues, and often, you know, we include partners very much so at the Whittington. I know it's not the same throughout the country or maybe even globally, but, you know, partners and family play such a crucial part in the postnatal journey. And think about some cultures where the postnatal period is treated in a very precious way, where close family, close friends absolutely are there around the mother and baby. You know, they're given special food, there are rituals around postnatal care, the baby's looked after, there's somebody around to help mother and baby quite a lot of the time. However, in this particular culture, that's not the case. Many families are isolated, they're on their own, and many for the first time, and circumstances are very, very different. So the help, they rely on us professionals, midwives and all the support workers and all our early years colleagues to really, really show them the way forward. So just to kind of think about the nurturing and how well do we really nurture them postnatally. And I would say that midwifery services still very much are traditional in the postnatal sense. We did have mandated visits before by the NMC. You know, when I qualified, and I'm sure Sue will remember this, you had to see a new mother and baby twice a day for the first 3 days, and then every day till day 10. And then, you carried on with some of them, but then you handed over to health visiting services. And over the years, that the standards around postnatal care have, I would say, okay, that's maybe you might say that's too much. You couldn't possibly keep that up. And not all mothers wanted to see a midwife every day. I take that. But now, if they get 3 visits in their routine postnatal care, they are indeed fortunate. And that seems to be the standard. And it's almost become custom and practice to say, we'll see them the day after they go home, we'll weigh the baby, and then we'll do the blood spot test on day 5. We'll go in again on day 10, and we'll discharge them. I'm very happy to discuss this afterwards, but that seems to be the pattern. But my question would be, why are we offering postnatal care? What's the purpose of it? Yes, some of it is around clinical, making sure the mother and baby are physically okay. They're recovering from the process and the baby is thriving. But I would say that what we offer postnatally has pretty much long-term effects on families. And if you think about the public health role of the midwife, we always consistently are promoting health for the mother, and also around infant feeding. We are trying to prevent ill health. We're trying to avoid women having poor experiences. We are preventing babies from being ill. And we do the clinical stuff around all the screening. But our professional advice and expertise is, I think, very valid. And I would say to the audience, how often do you have to run from a postnatal visit to a postnatal visit? You might have 8, 9 visits. You have a clinic to run. How much time do we really get to sit there with women and be with women and families? We're pretty good at signposting to other services, but how well does that happen? And, continuity. I mean, Elizabeth talked about consistency of information and continuity. And that comes up time and again with the amount of complaints. When the complaints do come in, it's often about inconsistent and conflicting advice. It's something to think about. But I think there's also a political thing around the way maternity services are funded. We know the money is behind labor care and labor, and the maternity package as a whole is bought. And therefore, for the postnatal side of things, you don't get that much funds in through trust. And so I think, there is some of that behind it in terms of the area of importance, if you like, throughout the mother's journey. We've got a mother and baby delivered, they're fine, we get them home, and that's it. And we provide a sort of a minimum level of service. And the other huge area was safeguarding, which Elizabeth talked about as well. And this is so important for all our vulnerable families. The amount of work you do. And I would say that a lot of our health visiting colleagues these days, a lot of their work is around safeguarding. And that old traditional way, clinics, all of that immunization, it happens. But the way they offer their targeted services now means that safeguarding is taking up a lot of their time. So then what have we been hit for? So hit with, well, to use the Cinderella scenario, so Cinderella did not get to the ball during the pandemic. There were just far too many restrictions in place. So we've got a standard routine postnatal care that was already been, if you like, minimized, and then it's been impacted again in the last year. So we've had social distancing, we've had uncertainty, and when COVID hit us, there was a lot of mixed messages around the PPE that should be worn. There was a lot of uncertainty around infant feeding because the evidence just wasn't there. And we were all finding our way around, how do we do this? And as an instant knee-jerk reaction, many trusts just stopped doing a lot of face-to-face stuff, and that included postnatal visits. And we had not only did our service do that, but also early years did the same thing. So where women would go to children's centers, for example, they all closed down, and then that schools did too. But there was reduced face-to-face contact for infant feeding, as well as being able to access services like children's centers and social services, etc. So think about how difficult that would be or is for very vulnerable families to overcome, where they already felt perhaps that the needs were not fully met. And in the last year, that need has even grown more. And of course, we were hit by staff absences as well. So then we went on to the virtual and remote world and all the challenges around that and engaging. And of course, it's kind of highlighted the inequalities even more because things like classes and things like postnatal stuff, we've had to kind of adapt the way we work to that. So just going on about that is that what we don't know is that the impact of COVID is yet to be measured in terms of how families have come out of it. And the public health messages also didn't help us. We were told to stay at home, stay isolated, and only travel and when absolutely necessary. So the impact on mental health, increase in domestic abuse, and breakdown of families has been more significant. And I think we're going to be looking at a COVID generation and potentially the impact of a whole lot of children who might be affected by it. So what can we do? I think we should reinstate face-to-face contact as quickly as we can. We do need to protect staff and need to give them adequate protection so that they feel they can get around and meet women. And we need to monitor well-being in different ways and be a bit more innovative in terms of offering support to women. And most of us can do that virtually over the phone, on videos, etc. And I think maternity hotlines are great for women to be able to access midwives, and including partners and family members, and that is really, really important. And signposting to early years provision. We've done a lot of work on updating our maternity information on the website because of the ever-changing guidance that we've had. And what we need is this. I think Elizabeth already has said about leadership, etc., but we need more time and investment. We need a lot more continuity of care. And we need, I think, postnatally, we need more measurable outcomes. This is something we don't have. Even the NHS long-term plan is a little bit vague on postnatal care. And involving our mothers in co-producing services postnatally, I think is really important. And working very closely with our early years team. It is very much a continuity of care from us to them. And we must try and hear the voices of women that we don't normally hear from. We must make an effort. And the whole stuff around perinatal mental health is really, really important, particularly in COVID times. So we can go to the ball. We can do postnatal care differently. And I think if we base it in the community, we encourage social capital. That's a team of midwives who actually provide, caseload, continuity of care. We can do examination of newborns in women's homes. We don't have to do it in the hospital. And I think that women meeting women, families meeting families, empowering them, helping each other is a really good way to go. So we need to think a little bit differently. So in summary, postnatal care cannot remain in Cinderella mode. It'll just fade away if we let it be that way. And we do have the power to change postnatal care that is fit for the 21st century. We just need to think differently, work differently, engage differently to make that difference. And remember, the old traditional way of providing postnatal care really is, I think, not terribly suitable for the now, for this day and age. So those are some useful references, and I hope you've got some questions for us. So thank you very much.
That's great. Thank you so much, Logan. That's really good. I mean, as you were talking, I was kind of thinking it. I mean, it's interesting to think, because when I've done any work in different countries, when I've talked about the postnatal care, people have been really, whoa, you go into people's homes, you see the mothers and babies, wow. And when you were saying that, I was thinking it could fade away. It could easily fade away, and we'd be losing something so important for women's long term, and babies, because there's two. That's the other issue. It's not just one person we're looking after. We're losing that really important opportunity. So thank you very much for kind of laying that out. We do have some questions too, which is fun, and I've got a question or two also in my little my kit bag too. But we've got someone, Fran, thank you, Fran, says, our fabulous MSWs seem to be playing an even greater role in postnatal care. While they do a brilliant job, how worried should we be that they're being used by stretch teams, including continuity teams, almost as an extra midwife? That's a very interesting question, actually. I don't know how. I think that's possibly more for Logan.
Okay, thank you. I agree with you. We have got some fabulous maternity support workers, but I think without a proper, if you like, I think boundaries for them, I think that they are bound to be stretched. I think there's been lots of talk about using them as almost a second midwife at home births and things like that. But I would question it, because where does the accountability and responsibility lie? I mean, it lies firmly with the midwife. And I would be worried about, kind of the training aspects and the increased burden it puts on maternity support workers, where they might equally feel vulnerable. I think they need to be able to have a voice to say, no, that I draw the line at having to be asking to do this particular task that I don't feel that I can do. Maybe they need to be empowered. And I know the RCM absolutely supports MSWs. I'd certainly love to see their role as a step up to becoming midwives, because I think they are key in the frontline work we've done. But I do worry about the midwife's role being sort of gradually fragmented, if you like, because the midwife is then so busy doing other stuff. And it's a very easy road to go down. I don't know what the full answer is, but I think people do need to stop and take stock about what they're asking MSWs to do and how comfortable they are with that. Yeah.
I think that's a useful kind of highlight, because it can be easy, I guess, for an MSW to be quite love the idea of doing a little bit more and having a better relationship, because it's very much with people, isn't it? Yeah. I don't know, Elizabeth, you seem to be nodding away.
Well, I very much agree with what Logan said, and I would. Yes, being at a home birth is one thing, which can be an absolutely lovely experience where the professionals don't have to intervene, but it's very important that they're there and able to do so. And I think postnatal care can simply be the same. Much of it, although we focused on some of the troubles that women have when they do have a visit, there is obviously pleasure and satisfaction in that, and helping a mum to recover, and seeing that a baby is putting on weight and doing all the things it should do, and that can be a lovely way of working. But spotting something that's wrong in postnatal care with either a new mother or new baby, I think that is a huge responsibility. It takes that really widespread training that a midwife has, which an MSW, however hardworking, brilliant, experienced, they just don't have that. And also, if they do spot something, what's the next step? I mean, a midwife has the capacity to refer quickly to medical backup. As I understand it, and this may be different in different parts, an MSW working on their own would have to contact the midwife in the team, and the midwife then has to pass on. And there are situations in postnatal care where a mum or a baby is seriously not right and help needs to come very quickly. And that's quite a lot to put on an MSW, to say that they've got to really throw themselves into it and maybe make a pain of themselves, if you like, to say this has got to be done, you've got to do it. Not easy, because in the system they don't have that authority.
No, that's really, I mean, I think that's a really good point. I mean, I know in some areas MSWs have taken a very much bigger role in postnatal care, and I kind of wonder, especially looking at the NMC proficiencies that come out, and also knowing how you develop expertise, who then becomes the expert in postnatal care. But that's to throw at the audience for you. Anyway, we've got some more questions. We have a comment, more than a question, from Georgia Wood, who says, I used to offer a continuity of care scheme which was available for mothers 24/7 for 6 weeks. Was such a learning curve compared to NHS postnatal care, and felt that I could really support families with all their needs. Well, that sounds a fantastic kind of model of care. And of course, with continuity, that's the sort of model we would all love. I don't know whether it would be possible. We'd need a bit more funding, I think. Let's go for Elizabeth's extra funding, a bit from Logan. Okay, Georgia Wood. No, we're going to Octavia Wiseman. She has many thanks, but how do we improve postnatal care when trust receives so little money for the service? Should we start with Logan again? I like to be mean.
I think that if we looked at care and just equated it to the amount of money we get, we're doing a real disservice for women. I think that within the package, within what we've got now, we certainly can do a lot better. And I think we can do it in different ways. And, for me, I think we need to stop the custom and practice of the traditional way of doing postnatal care and do it completely differently. And I think, Octavia knows very well the REACH pregnancy, antenatal pregnancy research is brilliant. And it's a sort of model that we could easily apply to postnatal care, postnatal women. In other words, we already have women coming to children's centers for postnatal care. So it kind of stops, midwives having to go to individual homes, etc. For those women who are well. And so that encourages that social capital, and is a better use of a midwife's time. And it's a bit like trying to encourage everybody to do continuity. And people worry about the on-calls, etc. But actually, if you did it in a very flexible way, for most women and midwives, it's a very good compromise. So I'm kind of thinking, if we look at traditional ways of working, that's where we haven't really succeeded in delivering really innovative stuff. We've got to come out of our comfort zones and think, how else can I do this with the sort of resources I have? And I think it, like you say, using the MSWs, but using them effectively in areas where they do really well, and things like postnatal care, and having that, if you can't visit women, can it be a phone call? Can it be a virtual, how are you today? Those little things really matter to women. So I think we need to stop being, going along very traditional lines. But that's just me. A lot of people may think very differently. But I really think, and I was a matron on a postnatal ward for a few years, and I really felt, and in the community, that what women wanted was somebody they could trust, they could talk to and open up to. They weren't asking for the moon. They were asking for something really, really simple. And I think we should be able to deliver that.
Okay, that's brilliant. Thank you. How about Elizabeth? She's
got
a glint in her eye there.
I'm aware that I'm addressing an audience who are in the majority midwives, I guess. But really, while I was doing my talk, I was thinking about the whole of postnatal care, everything from the moment of birth, really, through to the 6 to 8 weeks where the GP check should be happening. And I think for most women, they need some care during all of that time. Obviously not every day at 24/7 during that time. Well, I say obviously not, some women might, but that is where I think the Maternity Transformation Programme, which has done some wonderful work, and I have been part of that work, but I think all of us have managed to miss transforming postnatal care. And I'm not just talking about midwives, not just about health visitors, and not just about GPs. I've said leadership, and I mean we need leadership for that entire period, and it is absolutely what we don't have. There are excellent leaders in midwifery, in health visiting, and in primary care, but none of them is able to do that. So I agree. I think the amount of money at the moment, the way things are arranged, that is allocated to postnatal is frankly pathetic. We're always told that because women are at higher risk, because they're old, they've got high BMI, they've got this, that, and the other, that they need more intensive care during pregnancy and birth. Then what happens in postnatal, as I was saying?
I think you illustrated that really so well, actually. Both of you did.
Yeah,
that's
the problems don't go away. We need to rethink the whole thing. Why is the money split between antenatal, intrapartum, and postnatal when the whole focus is on continuity? Just forget that. For one woman, it's one journey. She doesn't stop and turn into a different woman. She needs continuity of system throughout, with accountability for what she receives. And that is not happening.
Can I be a little controversial?
Oh, no.
Could I wonder if it's because postnatal, or some midwives, some practitioners, obstetricians even, might find postnatal care a bit dull? Do you think that might account for some, because generally intrapartum care is very exciting. It's where that huge buzz of that new baby arriving is. Antenatal is very exciting because you're not quite sure where it's all going to go. I'm just trying to be controversial, really, and I wonder, because I sometimes wonder if that's a bit of care that maybe we're not as excited about, we're not as bothered. And I'm talking to two people who are very bothered about it, and very passionate, and I think a lot of the people who are listening are also very passionate, because that's coming through in the comments that are being made. But I wonder if that's shared, and if that might impact on why nothing much happens to change postnatal care. But being controversial.
No, I think you've got a point. Having managed postnatal services, I do know that there were some midwives who were absolutely passionate about it, but there are also individuals who don't want to be working on a postnatal ward or working in the community, for example, because it's just not their cup of tea. As you know, there's I love labour ward. I like being where their action is, or the antenatal side. But I think postnatal ward is often seen as routine and mundane, and forgive me if I'm using the wrong words. Probably, I don't think it is. I think it could be very, very exciting. But I think it's because of the way we provide it. We have a whole lot of people delivered, all in the same area, each with individual needs, but in a ward with perhaps only 2 midwives and a couple of healthcare assistants or MSWs. Now, how on earth are you expected to deliver that holistic care when, in fact, it's not mother now, but it's mother and baby, or even babies? And you have the same number of midwives caring for them in that way. So if the beginning of that postnatal journey is very sparse, if you like, the input is not great. And a lot of our community midwives then pick that up when they're going into the community. But they're finding themselves having less and less time to spend with mothers. So that the impact goes on. But I agree with you. I do think that it is an area of midwifery that sometimes has got a reputation for only attracting certain types of midwives, perhaps, or certain types of people who want to work there. and it's seen as not terribly exciting. But I think we, as midwives, we've just absolutely got to, we are there for these mothers and babies beyond birth, and we've got to get that message across. Absolutely.
Get that passion on. Okay. I might have another question or two. We've got Joe D'Agustin says, thanks so much. Really important to seek improvement here. So question, Team CMO is really taking off in terms of national leadership. I think who needs to now join the team to take a lead on postnatal care improvement? Wow, that's a little old question there.
Well, I did worry when I banged on a bit about leadership. I was rather hoping that nobody would say to me, well, who should be the leader for the whole of postnatal care? And I think Joe has put a very good question, which I don't have the answer to. At the moment, the way the system is organised, that there is no clear leader at all. There are, you know, if you like, postnatal care begins with an obstetrician being in the hospital, possibly seeing a woman after the birth, mostly not, I believe, which is a shame. And I think a lot of obstetricians would like to be able to provide some more follow-up, especially if there's been a complication. But I can't see them being given the accountability for everything up to 8 weeks, except in very, very rare situations with really a major medical problem. I'd love to see midwives enabled to provide care and leadership, but that is probably not going to be easy with the current workforce and the current capacity. Again, health visitors are very senior clinical professionals and could take that on, but it's not going to happen with the current workforce. And more or less the same applies to GPs. I know many of them would love to have more engagement with maternity generally, and a lot of others wouldn't. So that's, I don't know the answer yet. Maybe Jackie Dunkley-Bent will come up with a great idea, and she's certainly.
I should think she will. I should think she will. But I mean, the other thing is that leaders sometimes do emerge, don't they? So
yes.
This might happen. So thank you, Joe, for giving a nice, tricky question to do. We've got Paul, who says, personal perspective, our first child was born in April last year at the height of the first wave. Our postnatal care consisted of 2 phone calls, spot tests, GP vaccinations, and that's it. We haven't seen a medical professional since 16 weeks. Baby seems to be developing well, but what have we missed out on? And I think that's a kind of, I don't think Paul is expecting a huge list of the answers, but it's a very good point. And I think that goes back to what Logan was saying, because we're going to come up with this group of mums and babies who might have missed out on something. I don't think all will have done, because some of the previous maternity hours we've had, it's been quite interesting that some mums and midwives have set up different sort of programs to support them, have had different experiences and had, even though they've been isolated in hospital, postnatal wards, they've actually been able to talk to other mothers, which they wouldn't have done previously when, you know, in the olden days. But anyway, okay. And we've also got, I think, the last question now, and this is Barbara Senior, who says the education programme needs to change, e.g. the NIPE, and that's only one part of examination newborn, of course, should be introduced in the curriculum, as not all community midwives can do the NIPE. Well, Barbara, I mean, I'm very aware in the new proficiencies, and I know Logan will be, it's not just the NIPE, it's the holistic examination of the newborn, which is being integrated into the pre-registration curriculum. And I'm very aware all over the country, there's midwives like Logan, who's very much involved in that, in trying to get each curriculum to include the fundamentals of the holistic examination newborn, which incorporates part of the NIPE examination. And I know that there's a lot of midwives who've done the further education to do the examination newborn also. And as time goes on, that will happen. So I've answered that question. Sorry, I took over a bit there. Now, I'm very conscious that the time has marched along. We could talk about this forever. I'm going to invite both of you back at a later point. to see if postnatal care gets impacted a little bit. Maybe that Cinderella will get her palace, or go to the ball, or all.
We need a minister for postnatal care. That's what we need.
Gosh,
Yeah.
my goodness.
Yes.
Oh my goodness. I wonder if they're watching tonight. They'd be too busy doing their budget business. So please, I'd like to thank both of you, Elizabeth and Logan, for joining us this evening and giving us all, not the answers, but some answers and loads of questions and lots of thinking for us all to do around postnatal care and looking after mothers and babies and their families. So thank you so much. And I would also like to say that there will be people on social media later answering a few questions. This will be available by Friday to go, would be accessible. And now next week, the Maternity and Midwifery Hour is again 7 to 8, and it's chai and chat with the ASSAM, and that's the Association of South Asian Midwives, and that's, we've got Nafisa Anwar and Sundas Khalid next week, which would be lovely. So you'll need to bring your own chai, that much I know. So finally, take care of yourselves, look after your loved ones, and we'll see you next week. Thank you for coming.
The Maternity and Midwifery Forum brings you Matflix, video streaming from maternity experts. All your CPD and revalidation needs met in one place. Our expertly curated box sets are the perfect way to engage with the latest thinking, issue by issue. They make revalidation easy and are the perfect accompaniment to any project or university coursework. In addition to video from expert speakers across maternity and midwifery, there is easily accessible research and links to the latest government policy documents. Our reflective questions at the end are the perfect primer for your revalidation. In the same way the Maternity and Midwifery Forum provides certificates to show that you have attended these festivals, we can provide certificates for those who have consumed the content of a box set and submitted their written answers to the reflective questions provided by our curator, Dr. Jenny Hall. Midwives, maternity professionals and students, do not miss out. Subscribe to Matflix today. Box sets are just £17.50 each, or access to them all starts at £8.99 per month, and only £5.99 for Maternity and Midwifery Festival attendees. Students pay just £2.99 per month, and only £2.49 for Student Maternity and Midwifery Festival attendees. Check out the box sets at www.matflix.co.uk.